Ryan is coming here next from Illinois Orthopedic Network to talk about evaluation of the injured worker. He's a pain doctor who will introduce himself far better than I will be able to. I would ask everyone, when you guys get up and leave at the end, the chairs all snap back. So if you're going to leave when he's not done yet, if you could just be mindful of that so that it's not disruptive, that would be appreciated.
What about this one?
It's a hostile group here, but you did good.
Anybody hear me in the back?
Yes.
All right. I'm Dr. Rizwan Arian, and today we'll be talking about evaluation of the injured worker. I'm board certified in physical medicine and rehabilitation, and not everybody knows what a PM&R doctor is, so I'll go over that in a little bit. I'm also board certified in sports medicine. I went to the University of Illinois for undergrad, and I focused on biology. I went to medical school at Ross University, which is the medical school in the Caribbean. I went to the University of Chicago for my physical medicine and rehabilitation residency, and I'll go over more about what that is. And then I went to the University of Illinois for sports medicine and EMG fellowship. I stayed on actually at the University of Illinois for about 9 years as an assistant professor in sports medicine. So, what is physical medicine and rehabilitation? So some of our goals include enhancing and restoring functional ability and quality of life to those with physical impairments or disabilities affecting the brain, spinal cord, nerves, bones, joints, ligaments, muscles, and tendons. Another goal of ours is to maximize patients' independence and activities of daily living and improve quality of life. So I think this specialty is well suited to treat injured workers, as restoration of functional ability is one of our main focuses. So another way to describe physical medicine and rehabilitation is physiatry, not to be confused with psychiatry, which sometimes happens. Another name for what I am is a physiatrist. You may hear that term thrown around a little bit. Physical medicine is one of the newest specialties. It was first developed in 1936, and it was accepted by the American Board of Medical Subspecialties in 1947. It was basically born out of the treatment of injured soldiers. So when these soldiers were coming back, they would have amputations, brain injuries. They didn't know what type of doctor was the best fit for them. So the rehab doctors kind of stepped in and took that role over. The best way to describe physical medicine and rehabilitation is a mix of non-operative orthopedics and neurology. That's what I tell most of my patients when they come to see me. Basically, so there's inpatient rehab and outpatient. So I do a little bit of inpatient rehab in the subacute setting, but we're talking more today on the outpatient focus. The outpatient focus on physical medicine is an occupational injury, overuse syndrome, and spine and musculoskeletal. So a little bit about the organization I work for, Illinois Orthopedic Network. The initial evaluation, when a patient is referred to us, initial evaluation is done by a physiatrist such as myself, or another pain doctor, anesthesiologist. And then we have other specialties there that, if needed, we can use, including physical therapy, occupational therapy, surgeons, psychologists, what have you. When it's appropriate, we order appropriate diagnostics. We have an in-house lab if any lab needs to be done. And then I actually perform electrodiagnostic testing, which I'll go over a little bit more of this as well. kind of went over this already. So we have physical therapy, occupational therapy, and work conditioning as well. The previous lecturer did a good job on FCE, I think. They also have do pain medication management at this facility. They have an in-house pharmacy, so that kind of helps with the medication part of it. They perform the intervention procedures in-house. It's the surgical center, so cervical, lumbar, epidural steroid injections, cassette injections, median nerve branch blocks, radio frequency ablation, spinal cord stimulators. Those are all done in-house. And then obviously surgical intervention is necessary. That's also available. The main location is right around the corner, 712 North Dearborn. They provide case management, quick scheduling, you get a progress note, and work status when needed. And the facility is accredited by the Joint Commission and American Association for Accreditation of Ambulatory Surgery Facilities. So now we're moving on to the injured worker, enough of the early stuff. So the Bureau of Labor and Statistics reported that in 2013, 1.1 million musculoskeletal occupational injuries were present. So men accounted for about 61% of that. And then workers aged 45-54 missed the most days. Of those 1.1 million, 212, so 212,000, so about a quarter of the had back injuries. So the most common in the upper extremity is the hand injury, and the most common in the lower extremity is knee. So we look at primary risk factors for sustaining work-related injuries, and those are heavy physical work, which seems obvious, smoking, high body mass index, high psychosocial work demands, prolonged computer work, older age, and repetitive work. So believe it or not, the more you exercise, the more exercise frequency correlates with the reduction in low back pain. So those jobs that promote healthy living, they have their gyms in the workplace. There's a reason behind that, and it's been shown to reduce low back pain incidence. So one thing that I found a little bit surprising, educational interventions in biomechanics were not as effective as we thought they were. There's a study that I looked up showed a physical therapy-led program improved subject knowledge, but in those programs there was no reduction in low back pain rate, cost per injury, time off work, or repeated injuries. Another thing I didn't mention in the slide was lumbar supports. They're not effective in prevention or in treatment of low back pain, but when you're wearing one, it kind of reminds you that you have a low back pain injury. So it prevents you from it reminds you that you have an injury, so indirectly it may help, but the literature states that it doesn't really help. So associated conditions of those with work injuries. So 95%, which I found surprising, of claimants had comorbid personality disorder. So an example of personality disorder such as OCD, obsessive compulsive disorder. Another condition, premorbid depression, was more likely to develop chronic pain. Prolonged unemployment, increased physical and mental mobility and mortality. So work is good for us. Everybody should keep working. It's good for the injured worker too, to get them back to work as quickly as possible. So what happens when we see a patient? First, obviously, we get the history, do a physical exam, functional assessment, which we'll go over in a little bit. We order imaging if necessary, or an EMG, and or an EMG. And then there's supplemental assessment tools that we utilize. So history. It's imperative that we get the correct injury date, and also a detailed mechanism of injury. Another important thing to get is occupational history, and any history of any previous claim. Because this will identify risk factors for protracted recovery. So if they're coming in a second or third or fourth time for an injury, you might be inclined to think that they will have a longer recovery period because it's had it so many times. And obviously a medical history. You know, somebody that has carpal tunnel syndrome, do they have a history of diabetes? Do they have numbness and tingling in their hands before they started work? Or is that a component to their, is there diabetic peripheral neuropathy component of the symptoms that they're having that's kind of confusing the carpal tunnel syndrome picture? But we're going to go over that in the case study at the end, so we'll look at that a little bit deeper. Physical exam. So there's really only two objective findings. Everything else is subjective. One is reflex asymmetry. You can't fake reflex. So that's one thing we can hang our hat on. And that goes between any other physician. If another physician does checks the reflex, it's there, it's there, it's not, it's not. The other thing is atrophy. You can see atrophy, you can measure it. You can measure the circumference of a forearm, of a bicep, of a thigh, if there's muscle atrophy. Everything else is subjective. So range of motion, if you know, a patient might not get full effort. Manual, MMT stands for manual muscle testing. So patient might not get full effort for that. Sensory finding, they may say that they don't feel something when they actually do. So everything else is subjective, but the first two items are objective, those that can be reproduced by other physicians. And then obviously there's specific tests that you can do, like for the shoulder exam. I'm not going to go through all of them because we'll be here all for a long time, but there's specific tests for back pain, specific tests for neck, shoulder, knee. The first thing I do is observation when they're walking into a room. To see if they're able to walk, if they have any problems with their gait pattern. Also, you know, donning down some clothes. So for example, let's say they have a shoulder injury. I notice them taking their jacket off. Did they have any problem taking it off? And then all of a sudden they have limited range of motion when I'm doing my physical exam. So I kind of pay close attention to when they're disrobing to see if you know, there's any discrepancy between that and then also when I'm doing the actual physical exam. Even things like just getting up from a seated position, I look at that carefully as well. I think you guys already kind of went over the Waddell signs pretty thoroughly, so I think I'm going to skip that part. So next we go into functional assessment. So how do we know what the patient was doing before? How do we know what they can do? So first we look at their home activity. That'll help us establish their lowest level of function. So for example, are they able to do their laundry at home? Are they able to do the dishes? Those with back pain, they'll report to me that they have a difficulty just leaning slightly forward doing the dishes or while they're brushing their teeth. So that, just the finding out what their home activity will help with their minimal functional level. Are they avoiding responsibilities at home that are beyond expectations, which that can indicate other secondary gains? That one's actually hard to figure out though. Another way to assess function is the Oswestry Disability Index. It's basically a questionnaire for patients with low back pain. And it can identify patients at risk for disability. So they quantify disability, the lower the score, they have minimal disability, the higher the score, they have more severe disability. We'll go into the deeper the Oswestry Disability Index in another slide. The next thing is imaging. We'll consider that when appropriate. So it's used to negate or identify pathology, educate patients on normal findings, and then you have to correlate what you see on MRI with the patient's signs and symptoms. Because not everything you see on imaging is causing their pain. There was a study done some time ago. They took, let's say, there's 100 people here. They did MRIs on everybody, and 20 to 30% of them had facet problems, arthritis, spinal stenosis, pinched nerves, but they don't have pain. So it's very important that you take what you see on an imaging study with a grain of salt. So we always try to match up what we find on MRI with their history and their physical exam. It's really important. For some people, if you chase things that don't match, it's going to be a failed process. Abnormal findings, just like I said, abnormal findings in asymptomatic individuals are common. Next, something I do is EMG NCV. EMG stands for electromyography, and then NCV stands for nerve conduction velocity testing. And it's supposed to be done by either physiatrists, such as myself, or neurologists. EMG testing is integral in our training in physical medicine and in neurology. And we should always use it as an extension of our physical exam. We should never hang our hat on EMG, meaning that we have to put everything together. What we hear from the patient in history, what we see on physical exam, what the EMG findings are, and as well as what we see on imaging. So we should never hang our hat just on using electrodiagnostic testing. And it's used to clarify a diagnosis. We also use it when conservative treatment has failed. We use it, surgeons like it to plan surgical intervention, and then also for prognostication. So, for example, let's say a worker had a laceration in their forearm, and the patient referred to me for EMG to find out will they get wrist extension back because the radial nerve has been severed. So with the EMG, we can find out if there's any sort of message getting across from the nerve to the muscle that will indicate that, well, there will be some recovery. On the other hand, if there is no message that's coming across on EMG, then that is poor prognosis. So we use EMG for prognostication as well. Supplemental assessment tools. We talked a little bit about Western Disability Index. Actually, this is the one, I've used this before some time ago. It's a gold standard for low back outcomes. And like I said before, the higher the percentile, the more disability. This might be good to use pre-treatment and post-treatment to quantify disability. Other ones I haven't used, but they're in the literature. Neck Disability Index is the same as the Western Disability Index. It's just a questionnaire, but it's focused on questions about the neck. Same thing, lower the score, less disability, and the higher score, more disability for this. Another one that I came across was short form 36. I've never used this one, but in the literature, the physical, emotional, and social functioning. So this is one of the few that has emotional questions as well. This one, if there's a greater score, there's actually less disability. So some early predictors of outcome. So protracted recovery predictors. So these items, if some of these things are going on, then you might indicate a longer recovery time. So early use of opioid medication. So with the early you use it, you may not have the best recovery as you think you might. Premorbid psychiatric illness. That's one that I was kind of surprised about, but that's also a predictor of outcome. So those that have depression when they're coming in, it's going to be a poor outcome than those that don't. Then excessive medical services. You know, the patients that are undergone weeks and weeks of therapy, undergone many MRIs and lots of testing, they also have poor outcomes. Actually, Washington State is the only state that will treat premorbid, unrelated psychiatric illness that are limiting recovery and allow industrial conditions in order to improve outcomes. So there's only one state that's actually looking at premorbid psychiatric illness to treat those patients that have comorbid with their injury. Some environmental factors that predict outcome. Job satisfaction is actually a stronger predictor than job activity for filing a disability or filing a work comp claim. If you come across a patient that has multiple short duration jobs, that may indicate an inability to get along with others, so that's kind of like a red flag. If you have a patient that's been at the same job for a long time and they're filing an injury, you may be wondering about has there been any recent changes at work? Is there a new supervisor. Studies show that social support from supervisors improve work competency outcomes. So if you like your boss and your boss likes you, you will have a better outcome. Some items that may contribute to depression as a poor outcome. Loss of identity, financial loss, home stress. These can all lead to depression and also, in turn, cause poor outcome in recovery. Treatment. We start off with the basics. We start with RICE, rest, ice, compression, elevation for acute injuries. Then we move on to conservative care with physical therapy and occupational therapy. The way I use medications or interventional procedures, if patients can't participate in therapy, or if they're failing therapy, then we look to move to pain medications and interventional procedures. The way I think is that we use these other pain medications and procedures that we can bring down the pain and inflammation that the patient is undergoing so they can participate in therapy fully. Therapy is we feel rehab and physiatrist is a mainstay of recovery. And then work conditioning, work hardening, these are for protracted cases. This addresses work endurance through the use of strengthening cardiovascular conditioning. Workers advance from daily 1-hour sessions to 4-hour sessions. MMI stands for maximum medical improvement. So the patient can no longer obtain substantial improvement from the therapies they're at maximum medical improvement. So there's a team of people that are taking care of the injured worker. It starts with the patient, there's the physician, the therapist, the employer, insurance carrier, and attorney. So all these people have to be working in conjunction to get the injured worker back to work. So in terms of the coordination of care, when they return to work, we have to have clear work restrictions, and it's provided to the patient and insurance carrier at each visit. Having prompt clinic notes is important too, so that other people in the coordination of care group can know what everyone else is doing. It's important that the therapist keep in contact with the physician, especially when the patient fails to attend therapy session and if they claim to be in too much pain to participate in therapy. So it's important to stay in contact with the therapist. It's important for employers to accommodate work restrictions in the workplace as well. So consistent feedback from all members is paramount for a successful outcome.
Accident, neutral male, work
patient and family education. So expectation and goals, they should be established during the first visit. Work restrictions are based on the diagnosis and the physical findings. It's the employer's decision on whether or not to accommodate the work restrictions. So we encourage the employers to accommodate the workers. Family members with poor outcomes may undermine therapy. So family members that have maybe gone through something similar, might do a bad taste in the mouth and then the patient's workers' mind.
He's entitled to.
We like to encourage activity at home and at work within restrictions.
Had he worked his whole entire career?
Some pearls here. So identification of risk factors for protracted cases is essential to predict prognosis. So if you see a lot of red flags, you know that this case might be a longer case. You want to try to avoid time loss at work. So getting the patient back to work, whether it's with restrictions or full duty, as quickly as possible is important. This is new to me, but integrating cognitive behavior techniques will also be helpful. So treating underlying depression and anxiety will help in these cases. So work injuries are multifactorial in nature with physical, psychological, and social components. So a study looked at treating the psychological component and found that cognitive behavior therapy, an acronym of CBT, improved reemployment when compared to undergoing standard job assistance. So that's something that might be new that we should be looking at in the state of Illinois. Washington is doing this, but maybe we could be doing a better job at it. I just want to throw out a couple of case studies. So when a patient comes to us, let's say this is a 45-year-old male, he presents with low back pain secondary to a work-related lifting injury. So the first thing we try to find out, is the pain radiating or non-radiating? If it's non-radiating, it might just be mechanical low back pain, so a course of physical therapy is appropriate. Not everybody that comes in with pain needs imaging. They don't all need MRIs or X-rays. So in these cases, I start off with just conservative care. Send the patient to physical therapy, add restrict their activity, and then use some medication in terms of like anti-inflammatories and muscle relaxants. We'll stay away from imaging because you might be barking up a wrong tree if you find something on there that might not be causing the pain, and then also try to avoid opiates at the beginning. So let's say the therapy doesn't work, or they're not progressing like we would like them or they would like to. So then we look at changing the medication and intervention procedures. And like I said before, the way I look at intervention procedures is to try to get the pain and inflammation down enough so the patient can participate and gain something out of the therapy. And then we move to EMG. If there's a confusing picture, the patient's not progressing, are we treating the right level in terms of doing intervention procedures? So I'll show you that. So this is this patient with low back pain. So let's start with your left is normal disc. So the outside part of the disc is a rubbery tissue, and the inside is a jelly-like material. So the herniated disc is when the rubbery outside here breaks open and the jelly-like interior oozes out. So a lot of times it comes out posterior lateral, and that's where the nerve comes out of the spine. Now this is a picture of a disc level looking from the top down. So let's say you have a small disc problem, but if it's in the right location, it can cause a lot of pain. So my point is, let's say you have an MRI, and at L5S1, you have a large disc herniation, but it's far lateral. Say it's out here. And you're doing intervention procedures at L5S1, and the patient's not getting better. So that's when we look to do something like EMG. Is that level the problem level, or is it a different level? So let's say on the MRI, the level above it, L4, L5, there's a minor disc herniation. But that disc herniation, or disc bulge, is posterior lateral, and it's touching the nerve. So that's where the EMG comes positive at L4, L5, and not L5S1. The reason being is at L5S1, the larger disc herniation was far lateral, not even touching the nerve. The smaller disc herniation at the level above is hitting a nerve at L4, L5, and that level they haven't had any procedures done that. So then we kind of do the injection again at L4, L5 if the patient gets better. So what we see in MRI is not always the full picture. And obviously, the last thing is if they fail conservative therapy, send conservative therapy again. If they fail again, then I recommend surgical consultation. The next case study, this is a 52-year-old female presents with bilateral hand numbness, tingling weakness reported after repetitive work injury. So in this case, we try to cite exactly what kind of job are they doing, is it repetitive, how long have you been doing it. They say it works at night. So we start off with conservative care again. Activity restriction, start with some hand therapy, night splints, and then kind of go from there. And then again, if they get better, great, send them along their way, home exercise program. Send them back to work. If not, then we look at imaging and then EMG. If there's something confounding that, let's say we're treating the hand like it's carpal tunnel syndrome, but they may have a pinched nerve in their neck, which is actually causing the numbness and tingling in their hand. So that's when the EMG comes into play. So what we do is we do the EMG and we find out that maybe they have a pinch nerve in the neck that's actually causing the symptoms in their hand. So now we have to kind of rethink where our therapy is being directed. So we could direct it at the neck, the patient gets better, and then we move on from there. That's something called, and then there's something called double crutch injury. So that's basically is like a double whammy. So if you have carpal tunnel syndrome in your right hand and you have a pinched nerve in your neck, you don't know what's causing the numbness and tingling in your hand. So that's when you do an EMG to find out if it's one, if it's the other, or if it's both. So then you might have to get both treated. So at Illinois Orthopedic Network, we build a workers' comp fee schedule. In Illinois, it's very easy to find that out. In other states, it's a little bit gray. But here, it is what it is. So when we do our billing at Illinois, I'm not the biller, but I know a little bit about billing. We bill at the fee schedule, and I think that's the most appropriate way to do it. There's no like doubling or tripling or anything like that. It is what it is. Everybody knows what it is, and the end. The references are at the end, if you'd like to go over that. And then the slides will probably be available at some point. Questions?
One of your slides had to do with the outcomes and different things that can affect the outcomes. I was wondering if the increased rate of obesity among the population has been known or has been studied and has an effect on the outcomes.
It does. I think I had it on there. It definitely does. Yeah. So, I mean, I talk about that with my patients that come in with low back pain. That's one of the mainstays, is to lose weight. And then they say, well, I can't exercise. Then, you know, as you know, like diet has to do more with it than exercise does. But then we try to look outside the box, right? So it's not always easy, but then we find things like water therapy. So if we can find a place that do physical therapy in the water, that de-weights them, so they can actually start exercising in a pain-free range of motion, and then they start, you know, getting better that way. But you know, obesity is definitely a big factor. Yeah. So how the radiofrequency ablation works, so that's the facet mediated pain. The facet joint is on the back part of the spine. So when you lean backwards, you're actually leaning on your facet joint. So there's nerves that go to that joint. So before you do the facet, the radiofrequency ablation, you have to do what's called a median nerve branch block. So basically block the nerve that goes to that joint. And once you find out if the block is successful, then you do the radiofrequency. The radiofrequency lasts 6 to 9 months because that nerve tends to grow back. So I'm not sure about lifelong, but they do repeat it throughout the year. They have to have it repeated throughout the year. So, yeah.
The prior speaker spoke about the Waddell test, and I know you kind of brushed off that.
Yeah.
But what's your opinion? Is that an objective test for you, and do you perform it? Because it seemed like there was some...
I mean, it's more observational for me, right? So, like, it's part of my observation when I see them. So, for example, like, one of the Waddell signs is overreacting, right? So, at the beginning of my interaction with the patient, we'll put our hands on them, we'll check the area, and, you know, check for tenderness. And then, you know, we'll kind of, like, sneak in there maybe later on, like, when we're repositioning them on the table to do another test. And then if they don't have the same reaction the second time, that's overreacting. That's a positive Waddell test. So there's some, you know, something else going on that we have to look into, possibly malingering or something. So I don't do it like strictly, but it's always in the back of my head. Is this worth the patient actually, you know, presenting themselves as a true self? Or are they not?
What are the DSM-5 diagnostic criteria for malingering?
I'm not a psychiatrist. I'll have to.
Oh, so you don't diagnose with malingering? Okay.
No, I don't. Sorry. Our brother-in-law's addiction psychiatrist.
All right, I guess we'll talk to this.
Okay, thank you so much for your time. I appreciate you listening to me. Okay.